several years ago, in 2012 specifically, another virus appeared in Saudi Arabia, the MERS coronavirus. All those viruses originally came from animals, and we think that they came from the bat, but they have gone through to the humans through an intermediary host. In the case of SARS, the intermediary host is the civet cat. And in terms of MERS, it is the camel. Now, we're dealing with another virus. This virus is now called COVID-19. We also think that it came from animals. We don't know yet what is the intermediate host that transmitted this virus to the human, but we think it's the pangolin. So as you see here, the first virus here, the SARS virus in 2003, came through the civet cat. The MERS came through the camel, and we think that this virus maybe originated from the bat through the pangolin and started in a wet market in China, in the city called Wuhan, and then spread to the rest of the world. Just to give you a description of what happened during the first coronavirus, the SARS in 2003, total cases around 8,000, number of deaths 770, with a mortality rate of 9.6%. The virus, the outbreak is contained. We don't see any more SARS at this point. It was contained on July 1st. Arabia, it remained in Saudi Arabia. Total infected 2,400, 2,500. Total death is 858. That is a mortality rate of 35%. So you can see it's much severe infection compared to the SARS. The infection that we're dealing with right now, total cases so far, 125,000. Total deaths is around 4,000 now. It started from in China, it spread to more than 116 countries so far, with a mortality rate of 3.3%. So we need to understand the pandemic. So in order to understand what will happen, we need to understand the pandemic. And the pandemic goes through stages. It starts with the initiation stage, where you can see cases here and there. It may peak up a little bit and then decelerates and then goes up till it gets to a point that we call a critical point. At that critical point, we see acceleration. And the number of cases would go up very high to reach the peak before they start going down and decline before it disappears. Now, this is the epidemiological curve of what happened in China. And you can see this is the date of onset of the symptoms, and this is the date of report. But you can see how it accelerated to the peak and declined, and now we see minimal number of cases in China. That's what we need to follow in our epidemic here, pandemic here in the States. We need to see where do we get to the peak, and we need to see the decline. As long as you see that the cases are actually increasing, we are in the acceleration phase. And you can see that this is as of March 2nd. Now, this is the number of cases today in the whole world. You can see 127,000 cases. So far, we have 4,700 deaths and total recovered 68,000. It is very important when you calculate the mortality rate. The definition of the mortality rate is number of deaths divided by number of confirmed cases. So now you can look at this, you would say the mortality rate is 4%. However, you should know that the cases that were diagnosed today are included in the total confirmed. Those cases did not progress yet to know whether they're going to become severe, whether they're going to die or not. At the end of the pandemic, we would know exactly what is the mortality rate. This is exactly what happened with SARS. During the endemic, it was around 4% mortality rate. By the time everything is finished, it was 10% mortality rate. At the same time, while this is the confirmed cases at this point, we don't know how many other cases in the community they are not confirmed. And this virus, okay, it's everything together, right? And this virus is a lower respiratory tract virus. It actually attaches to the ACE receptors, the angiotensin converting enzyme receptors. That's why somebody is actually advocating that maybe the ACE inhibitors might work in fighting this infection. And that's why it was described initially. There's a study from China showing the evidence of CT scans, evidence of the finding on CT scans for those patients. We do not do CT scans for those patients. Chest X-ray is fine unless there's an indication. Now, I'm going to show you what happened in the States from that single case till today. As of the case is January 20th, and then you can see the that would be the initiation phase, where we see cases here and there. We heard about a case in Washington, another one in LA, here and there, till the 29th of February. Total number of cases 68, one death only. After 5 days, 221 days, 221 cases. Total deaths, 12. This is the 5th of March. After 2 days, doubled. What does that mean? There are so many cases in the community that were not diagnosed. It cannot double in 2 days only. What we know, the doubling time of the pandemic is 5 days. It should double every 5 days. So it doubled in 2 days. That means we started testing more people who are in the community already. On the 10th, doubled, another 2 days, 800 cases, total deaths, 26 cases. Today, doubled again, 1,400 cases in the States. So you can see how every 2 days we're dying. This is only because the test has been scaled up. The awareness of physicians to look for the disease is there. For every case you diagnose in the hospital, there are 5 other cases in the community, because the one that goes to the hospital is the severe one. The ones in the community are the milder one. Now we need to assess how severe. Why this is taken that much in the media and everything, everybody is worried about this. Because what we call the severity index, the pandemic severity index, and this is the old scale. If the mortality rate is more than 2%, it is category 5. And so far what we see is mortality rate above 2%. So it is category 5. If the attack rate in a population, this is based on 2006 census of the S population, if the attack rate turns out to be 30% of the population would have the virus, we're going to end up with more than 2 million deaths in the country. This is a new tool to assess the severity of the pandemics. And we're taking 2 factors in this assessment. The first factor is measure of clinical severity, how severe the disease is. And the second factor is how easy to transmit the virus. And as you see, we have 4 quadrants. This would be low severity, low transmissibility. And this would be the highest severity, highest transmissibility. The mouse is not showing. The right upper would be so I should not waste my time. And okay. So the right upper would be high severity, high transmissibility. The left lower would be the lower severity, lower transmissibility. Now you can see those circles inside this assessment tool. The one all the way to the right, in the right upper corner, is the pandemic in 1918. Had a very high transmissibility rate and very high severity rate. And you know that the number of deaths estimated between 20 to 50 million people. The 2009 H1N1 pandemic that occurred in 2009 had a medium level of transmissibility and a low level of severity. Now I need to elaborate a little bit about the tools that they use in order to determine transmissibility and severity. So let's start with the severity. So first is the case fatality ratio. And that's what we just determined here. That is a dynamic number. But we know it is going to be above 2%, unless we end up with having so many other cases that are not diagnosed. At that time, it will go to below 2%. So if it is more than 1%, it is already to the highest level. It's number 7. And we're already there. So this is the highest level in influenza pandemic. And again, we're extrapolating this to the coronavirus. Case hospitalization ratio. If it is 7% or more of the cases that are hospitalized, this is the highest degree. So far, we know it is about 20%. Number 3 is death to hospitalization. Number of deaths of those patients who were hospitalized. We know that 5% of all patients were in the intensive care unit. That is 25% of hospitalization. Half of those patients in the unit died. So we have a very high death to hospitalization ratio. Now, if you go to transmissibility, we don't have everything yet. We don't know what's the attack rate in the community, how many of us will get the virus. We don't know the attack rate at the school or at the workplace. What we know is the basic reproductive number, and I will talk about that. And so far, this is a number that will indicate how many, if there's one case, how many others will be infected because of that one case. And as of now, we know it's 2.2 to 2.5. So that means every patient can infect around him 2.5 people. 2 cases will end up 5 cases. So if we go on to apply what we know right now, I think we're going to be here. Transmissibility is very high. Severity is very high. We don't know about transmissibility yet. So it's going to be somewhere here. Of course, the higher the transmissibility rate, the higher the attack rate. So we end up with disaster. If we have a high attack rate, that means if we have a rate of 30% in a population of the United States of 300 will be infected. If you're talking about 20% of those people are hospitalized, that's increased huge demand on the healthcare system. And if you're talking about 5% of those patients will go to the intensive care unit, that is going to overwhelm our capacity in the ICU. So let me tell you how we approach the pandemic. Since we learned that the pandemic would go from initiation phase to acceleration phase to the peak and then the decline. The first thing that we try to do is let's push it forward. Let's push it a couple of weeks so we can get prepared.
we can get the equipment, the supplies, the staff, and everything so we can get ready for a huge number of cases. That's number one. And number two is, let's try to pull that peak down. Let's minimize the number of cases in the community that are going to be affected with this virus, meaning that let's decrease the attack rate in the community. And the last one is, let's spread it over a longer period. You can see that the blue line is the capacity of our healthcare system. If we're going to get all the cases above our capacity, the mortality rate is going to be very high. So what we need to do is we need to make sure that all those cases are spread apart, where we can get those in different times, and we can cure those patients and be ready for the other patients. Unfortunately, and that's what's going to be with the illness, those cases are staying in the hospital between 2 to 8 weeks. That's a huge demand on the healthcare system. What we need to understand is the transmission dynamics. How do we get this virus transmitted? So the initial transmission was from the animals. So it happened, there's a jump from animals to humans, maybe once or more than once. It's interactions at that wet market in Wuhan. And then we have a proof. There's a human-to-human, person-to-person transmission. This is happening with a close contact to each other. If the distance is less than 6 feet, the risk is higher to get contacted with the person and get contaminated with the virus. It is transmitted through the respiratory droplets produced when we talk, when we cough or sneeze. And I'm going to explain droplets in the next slide. And it is also spread from touching the surfaces and then touching the face. So somebody sneezes on that surface, I come and touch it, and then touch my eye, nose, or mouth. I get the virus. Now, it even gets worse. There's a possibility that it is airborne. And especially, most of you are doctors here, especially in the intensive care unit. There are certain procedures that we do in the ICU where we generate aerosols. And those are airborne, meaning that we can breathe in the virus. There's a possibility that this may happen also in the community, but it's not well described or determined yet. So the illness starts with, unfortunately, a very long, relatively speaking, incubation period. Compared to H1N1, it was 2 to 5 days. We have 1 to 14 days. And that's why those people who came from abroad and having fever or contact with others, they were quarantined for 14 days. And then you have the illness, and that illness could be mild, moderate, or severe. We'll talk about that. Before resolution of the symptoms, the duration can be between 2 to 8 weeks. Now, the virus was isolated in the respiratory secretions, anything coming up from the respiratory system, upper or lower, in the blood and in the stool. And there's a possibility for fecal transmission of the virus. It's not been confirmed, but the virus can be measured, and in fact, the patient which we've seen here in Illinois had it in the stool. We don't know if the patient is contagious only during the illness or before the illness. In fact, there's a study that was just published yesterday that I'm going to present next, indicates that the transmission can occur in the incubation period before even any symptoms. We don't know if all patients will have the same degree of shedding? Whether it's mild, moderate, or severe disease, do they have the same degree? And we don't know also if the patient is cured, how long is going to shed the virus after that. And that's why we actually now, in order to release the patient from the hospital, we need to have a proof of a negative PCR twice within 12 hours or for 24 hours. At the same time, we don't know whether this has vertical transmission from the mother to the fetus and whether it goes through the lactation. However, if we need to extrapolate data from the coronavirus, the MERS, or the SARS, there was no transmission to the fetus and there's no transmission through lactation. However, when you breastfeed the baby, you are in close contact with him. You can sneeze, so you need to make sure that you don't contaminate the baby also. And there's a concept of super spreaders that we've seen in the MERS. Patients who are very sick, they are very contagious. They infect so many people around them. We don't know if this is present in this illness or not. This is a proof that you can transmit the virus in incubation period. This is just published yesterday. The index patient came from China to Germany for business meeting. Patient 1 had close contact with that person. He did not show the symptoms till the 24th of January. The contact was on the 21st. Patient number 2 attended the meeting and got infected too. However, patient number 3 and patient number 4 did not attend the meeting and they got infected. And when they looked at the contact with the patient number 1 or patient number 2, look at this. They both contacted those patients prior to their symptoms. So those patients were contagious even before they showed any symptoms. And this is to illustrate the concept of droplets versus airborne. For any droplets, and you can see here, droplets is the different particles actually together, including the virus with the water. When somebody coughs or sneezes, it would be expelled out of the body, and depending on the size of that droplet, if it is more than 10 micron, it would actually drop no more than 3 to 4 feet. In fact, less than 3 feet. If it is more than 100 micron, it would be 1 to 2 feet. So somebody sneezes, if it is in that size, it will just drop. And that's why we call it droplet. However, if the water evaporates, the droplet will be called droplet nuclei. At that time, it is airborne, and it can travel longer distance. And that's what I meant by airborne. So at that time, it does not matter if you're close to the other person. However, we don't know yet if patients in the community are generating droplet nuclei. In the hospital, they are for sure generating those nuclei in bronchoscopy, non-invasive mechanical ventilation, nebulized treatments, intubation, tracheostomy, high-frequency ventilation. All those maneuvers, they require N95, goggles, and everything. We'll talk about that. So the influenza and coronavirus is mainly droplet. However, we cannot rule out in certain situations that it can be airborne. The other component that we need to understand is how many persons will be infected in contact with one person. This is what we call the R0. The R0 is the basic reproductive number. So if the R0 is 2, that means one case will infect 2. If it is 18, one case will infect 18 people around it. And to give you an example, measles, very contagious. And you can see how easily, when we had the measles, how easily that disease is transmitted. Ebola virus is 2, HIV is 4, Zika virus is 6, mumps is 10. Our Virus now, it is 2.2, maximum 2.5. How is the virus inactivated? Of course, it can be inactivated by our immunological system. The virus can survive on the surfaces for a long time. It could be hours, it may be few days. It depends on the quality of the surface, the type of the surface, and the temperature. Different studies have been done, and we cannot give an answer for sure that it survives for 3 hours or 9 hours, but it's at least 3 hours. And it can be inactivated easily with any product that contains hydrogen peroxide, ethanol, and sodium hypochlorite. So what is the clinical syndrome? The incubation time is 1 to 14 days. On average, the median is 5.2. Most of the patients had it around 5.2 days. And then symptoms would be mainly fever, cough, which is non-productive, myalgia, shortness of breath, and if we do CT scans, we find CT scan findings on more than 86% of the cases of evidence of lower respiratory tract infection. We can diagnose it with PCR, and we need to send both nasopharyngeal and oropharyngeal swabs. And also we can do sputum and bronchoalveolar lavage. 81% of the diseases were mild. Walking around, no need for hospitalization at all, mild cough, a little bit of fever, nasal congestion, and that's it, like any other flu. 14% were severe, requiring hospitalization. If you add the 5% that were critical, requiring critical care, we're talking about almost 20% of the cases required hospitalization. More severe disease in advanced age and in comorbidity, such as heart failure, coronary artery disease, hypertension, diabetes, chronic lung disease, COPD, asthma, and cancers. We mentioned diabetes, hypertension, in addition to immunosuppressed patients. The mortality rate that we talked about, it is a dynamic number. As I said, there are different reports. It depends on where are you in the pandemic itself, in the outbreak itself, and how many other cases in the community that we did not diagnose. It could be around 3.5% today. Those are the most common symptoms, as I mentioned. Almost 88% of patients would have fever. However, in the Chinese study, 50% or only 45% of patients had fever on admission or on presentation. They developed fever throughout their course in up to 88%. So taking the temperature and screening patients would likely going to miss a lot of patients. And this is a procedure that's used in many airports. Dry cough is seen up to 70%. Fatigue is next, 38% to 40%, and shortness of breath, almost 20%. Mortality rate is different based on the age. Unfortunately, the older you are, the more likely that you're going to die. But starts from age 50. Thank you very much. You all above age 50. Okay, 1.7%, 1.3% for age 50 to 59, 3.6% for 60 to 69, 8% for 70 to 79, and 15% for above 80 years and old. Those patients who have chronic diseases had a higher mortality. For cardiovascular congestive heart failure, almost 10%. Diabetes, 7%. Chronic respiratory disease, 6%. Hypertension, 6%. Cancer, 6%. How are we going to prevent? I'm going to give 3 different scenarios. What if we are not sick? if you are not sick, what you're supposed to do. Number one, keep away from others who are sick. If you see someone who's sneezing, coughing, stay away from him. Number two, limit face-to-face contact with others as much as possible. Even talking can spit some saliva and you can get infected by that. Number three, avoid unnecessary gathering. This includes all big gathering and presence in areas that are crowded and not ventilated, such as the subways, okay, theaters, all the closed room and crowded room, the mosques, the churches. Okay, those are very high risk for transmission of the virus. Airplanes too. Okay, anything, the highest. In fact, actually, CDC is asking people not to go on the cruise anymore. They stopped it. Okay, so you cannot. If you work in a hospital and you go on a cruise, you have to be quarantined for 14 days before you can go back to work. At Sanford Health, in our hospital at University of North Dakota, they classified travels as the following. If you travel to level 3 CDC classified country like China, South Korea, Italy, and Iran, you're going to be quarantined for 14 days. You cannot go back to work. And now they stopped all the planes, which is very appropriate, coming from Europe. You can see the number of cases in Europe going up, 2,000 cases in France, 2,000 in Germany now. So if you visit, this is level 2. If you visit those countries, you need to report to the healthcare office in the hospital at Sanford before you can start working. That's why we canceled our trip to Mexico. Because Mexico is also, even though it is 8 patients so far in Mexico, however, it's category 2 by the CDC. It is expected to increase. So they need to, the purpose actually, that's why I presented that graph. You need to prevent access of this virus to this country. You need to block, you need to stop where this virus is coming. We have viruses circulating, we need to deal with that. However, we don't need more people to come with this virus into this country. So that was the purpose of putting all those restrictions on the airports and the other ports. No, travel within the state, the risk is within the plane. It is within the plane. It is a closed, non-ventilated environment. If it happens that you're sitting to a next person who's got the virus, the likelihood that you're going to get it is very high. Okay. So as I said, I'm not sure if somebody sneezes strongly and he generates aerosols, you can inhale that. Okay. It's not proven, but it is possible. So it is better to limit it. However, it is not, actually, this is your personal decision. It is not advised that you limit interstate travel yet. The risk is still very low. However, we don't know how many cases are in the community yet. Avoid shaking hands, hugging and kissing, especially in our culture. Okay. Clean your hands often for 20 seconds with warm water and soap. You're not going to find the sanitizer anymore. Okay. We'll be lucky if you find anything. If you store something in your home, great. Okay, but you should not worry about it. If you have access to soap and water for 20 seconds, wash your hands very well. And we'll talk about that. Cover cough and sneeze and avoid touching face with unwashed hands. There is no need for us in the community to wear masks. You can see all those pictures on the media from China, everybody's wearing masks. Well, if it gets to a level where the attack rate is high, probably yes. At this point, there is no need for masks in the community. So if you walk around, you don't need to, just keep a distance. And then you need to pay attention to all high-touch surfaces, like the elevator buttons, the door handles, the mouse of the computer, if you're working, the keyboard, those areas that can be touched by many people, very likely that can transmit or the virus. So that's if you're not sick. So what if you are a household member, an intimate partner, or a caregiver in a non-health care settings in suspected or confirmed case? What if your brother, your mother, your son has the virus, confirmed or suspected? Most important is to monitor the symptoms. Unfortunately, the symptoms will take a long time before it gets worse. And this is actually a big problem in the transmission. As compared to MERS, when they get the virus, the patient becomes very sick. What does he do? He goes to the doctor right away. We identify the case and we isolate it. In this virus, the infection is mild in more than 80% of the cases. And it takes longer time till, if it gets worse, it may actually take a few days before it gets worse. So that's why those patients with the mild symptoms, they may walk around not feeling that they are sick, but they are transmitting. So we need to, if we're caring for someone, we need to pay attention to his symptoms. They may get worse, and they may need to be hospitalized. You need to stay in another room and use separate bathroom. Do not share with him the same bathroom. Do not allow visitors to the house. The room should be ventilated well and often. You need, same thing, clean your hands very often for 20 seconds with soap and water. If you're going to use alcohol, it has to have at least 60% of alcohol. Avoid touching eyes, nose, and mouth with unwashed hands similarly. You need to wear a disposable mask if you get close, or if you touch or get in contact with the patient whom you're caring for. So here the situation, if you know a case that is suspected or confirmed, you need to put a mask when you get close to him. Same thing, you need to clean all high-touch surfaces every day. Avoid sharing household items with the patient and wash laundry thoroughly. That's if you're taking care of somebody else. What if you get sick? Stay home is the best thing to do, is to stay home. Do not get out of home unless you need to go for medical care. If your symptoms get worse, if you start getting shortness of breath, at that time you need to seek medical. If you need to seek medical care, please call the office first. Tell them that you have cough, shortness of breath, and fever. You don't want to go to the office, sit in the waiting room, nobody knows about you, start infecting others in the waiting room. Same thing in the ER. If you need to go to the ER, the first thing is to tell them, I have cough, fever, shortness of breath. They screen you, they put you on the side, and they actually get a better care because they are going to bypass the whole waiting time for the ER. So it works for your benefit. Okay, especially at Loyola. Okay, if you are sick, you need to wear a mask. So at least you limit the transmission to others. You need to cover your coughs and sneeze and clean your hands often. Avoid sharing personal household items. Clean all high-touch surfaces every day and monitor your symptoms. If you cough, please do not do this. You can either put a napkin or you can use the side of the jacket or anything, so you can, and even if you use this is contaminated. Okay, so the best thing is to cover it with the tissue or napkin and throw it away. You need to wash your hands either with soap or with the sanitizer. If you wash your hands, you need to do this for 20 seconds and make sure that you cover everything and in between and the fingers like that. and you do it like that. Okay, so and you know, I would suggest to trim your nails for this next few weeks actually, so you can wash your hands very well. If you work in the hospital, you know that we're putting those patients in negative pressure rooms. So we're doing airborne in the hospital. And you need to put the N95, which has a higher degree of 95 stands for 95% of the particles that are less than 0.3 micron that can be actually stopped. In addition to the contact precautions, you do airborne precautions, and very important, you put goggles. If you have the tent, the pressurized tent, would be great. However, you can't hear anything once you put it. You can't hear anything patient is telling you. In the ICU, we may not necessarily need to hear anything. Patient is intubated already. And those devices should be taken off before you leave the room. And there's a special, you need to do the fitting test. If you did not do it, please do it. If you have a beard like my son, you need to shave it because it does not fit well. And actually, in order to, for you, if you don't have time to do the test, just try to put it on and inhale. It should collapse. If it doesn't collapse, there's a leak. When you exhale, it should come up a little bit. If it does not do that, it's leaking. So you need to go and get fitted. Treatment. There is nothing special yet. Supportive care, prevention and management of complications, and you probably heard about specific treatments. Yes, we have used the lopinavir in the MERS coronavirus that we had in Saudi Arabia, and it looks like it may have some benefit. We need more studies, better studies to confirm this. Interferon alpha, chloroquines, the most promising probably remdesivir. It's similar to the oseltamivir, the Tamiflu, and there's a clinical trial by NIH that is actually going on right now in Nebraska. So it takes some time before we can get the result of this. In conclusion, wash your hands frequently. Avoid close contacts with others. Do not touch your face with unwashed hands. Avoid gathering. Inform your primary care provider for any fever, cough, or shortness of breath. I want to say one thing about us, the healthcare workers, who go and work in the hospitals where everybody else is afraid of getting close to those patients. During the plague outbreak, physicians died in the medieval Europe. During the yellow fever outbreak in Philadelphia, 1793, physicians and other healthcare workers died. During the Ebola epidemic in 2014, and in China now. And we know that physicians actually sacrifice their life in Syria too, for different reasons. So though such mortality reflects the willingness of healthcare professionals to put themselves at the risk of care, at the risk to care for others, it can also indict governments that ask clinicians to confront outbreaks without the staff, space, and systems. And we all experience this in our hospitals here. We need to get to, in 2020, we should have had better preparation, better system, better healthcare system to be able to confront the pandemic that we are facing right now. Thank you very much. So I think we're going to make some Q&A sessions here. And also we have some announcement that are going to be given by Mr. Hani Atasi.
Thank you, Dr. Mazen. I mean, that was really a very insightful presentation. Thank you very much. So what I wanted to really give you some update about the Mecca Center and what the Mecca Center is really doing for this. I mean, this is very serious. We all know that the state of Illinois has made or declared a disaster proclamation on this issue. We've seen local schools are closing, universities are closing. So we are really taking this very seriously. So what I did, I asked the executive committee and the religious affairs committee to meet yesterday. We talked about it. We wanted to take mitigation measures on this. We wanted to be proactively helping our government and our country with their mitigation measures. Meaning not only that we care about the well-being of our community, but we care about the well-being of every single American in here. And this is the reason we met yesterday, and we take our approach is that we want to be proactively controlling the spread and take an active role in controlling the spread of the virus. Therefore, we have decided to suspend all our programs, including everything that we do, including the Jum'ah prayer. And that is upon the consultation of Dr. Mazen Khairallah in here. And then we will continue to watch for the acceleration of the virus. And as soon as we see there is a moderation of acceleration or even a slowdown, then we could reassess our position on this. We take it very seriously, and inshallah, we're open up for Q&A for everyone you need. Okay.
Thank you very much. Well, unfortunately, testing is not scaled up yet to the level that we need. They are selective. It is available through the Illinois Department of Public Health, through your own county. It is not available locally in the hospitals yet. However, it's been promised that by Monday, we're going to have large number of kits distributed to different offices of the health department.
How long does it take to get the results?
Well, now the local office is sending it to a different office. The test doesn't take more than 2 hours to be done. However, the logistics associated with this, because they're screening first, they're taking history, they filling forms, getting back to you, collect the specimen, send it to them, and then send it to another office if they don't do it locally. It's actually a turnaround time around 2-3 days.
What's the finding of this X-ray?
There's no specific findings for coronavirus on the chest X-ray. Like any other viral pneumonia, you can have focal infiltrate, you can have interstitial infiltrates, patchy infiltrates, and can progress into ARDS.
I'm Dr. Shazad from Franciscan Hospital, the primary care and urgent care I work. So in our hospital, what they did, they contact Quest. So we are advised the physicians should be taking the specimen, and then they will be passing it on to our labs and our labs right away, like we have in-house, and they will be sending it to Quest, and results turnaround time is 3 to 4 days, like you mentioned.
And every physician should know the procedure that is applicable to the hospital and the county that you're in. So please find about it so you're not surprised to know about things that you don't know. And then
I cover some nursing homes and psych centers and disability center in the city on very elective services like annuals and STD screening. Should I suspend these services now?
well, we haven't seen cases in nursing homes yet. It is possible that outbreak can happen. I would not actually suspend those services. In fact, those services are needed. However, I would take the necessary precautions. Muaz? Okay, go ahead.
I've heard that some people are also just outright avoiding restaurants or getting food from certain locations. Would you say that that's a
Well, if the attack rate is high, we don't know what's the attack rate. At that time, those people who work in services can be a source of bigger problem in the community. I would at that time try to avoid going to those areas where there are services delivered by other people, especially if those services, if those people are actually relying on their job to do their living. Because if they get sick, they may not report it. They may come to work despite, because they know if they report it, they're going to be off, not able to get the income that they need. But at this point, the attack rate is supposed to be, it's suspected to be still very low. So the risk is very low, but it is there. Thank you. And then the person behind you next, he has the nurse. Yeah, no problem. But next, after that, give it to the person behind you. After that, give it to the person. Yeah. Go ahead. That's what I'm saying. Mm-hmm.
It was very informative lecture.
Mm-hmm.
Thank you very much. But I have a question. Say if you want to let tomorrow Juma prayer because we are not well prepared, it's fine. Somebody suggests that we could do a small scale Juma prayer here in the banquet. Then I would say each individual come here with a nice square towel, very clean, put it in front of him, and put his face on top of that. Besides that, every individual has to wear a mask or gloves or sustain from shaking hands. I would say that's probably would take care of that.
Well, the recommendations are based on studies and science, and it depends on what's our intention to do in terms of our action. Are we trying to mitigate the impact of this virus on our community, or are we trying to stop the transmission? If we need to stop the transmission, this is in closed area, very crowded, and there is no better way to transmit the virus better than what we do in our prayer. We sit down, we sit for the Jum'ah for like half an hour, somebody can sneeze, and then when we go and pray, that person will go and change his position from that area to another area where he's standing. And another person will actually come and pray. And when we pray, we almost rub our hands on the carpet. This is very risky. And I think, yes, the measures that you're talking about, we're taking those measures for the regular prayers, where there's limited number of people attending. So that's why if you saw the notice, it is only for Friday's prayer, but the regular prayers are still going on with some restrictions, some interventions that are going to restrict the transmission of the virus, similar to things that you mentioned without the mask.
The question is, what is the line for the virus in the air? What is it like?
It's on the surfaces, it's at least 3 hours.
What's that?
On the surfaces, at least 3 hours.
3 hours.
It may be much higher than this.
Regardless whether the weather wet or dry or
in warm temperature, it is shorter life. You're welcome. Thank you.
I'm going to skip that because that is a source of transmission.
Okay, thank you very much. Excellent.
There are reports coming out of Italy.
you want it or you don't.
Well, it's already in my hands. There are reports coming out of Italy which suggest that the younger age group people, 30, 40, 50s, are getting severely affected. We were under the understanding that the mortality that you showed, 5% is in elderly population, more than 60 years with comorbid situations and conditions. That is number one. Number two is comorbid conditions like coronary heart disease. That is what CDC has recommended. There are millions of people with that. Are those people at high risk?
Yes. To answer the first question, younger patients can have severe disease too. They can progress into ARDS and they can have severe respiratory failure. And the mortality rate for those cases is also high. However, if you put the mortality rate within everybody who's got infected, this population had a mortality rate of less than 1%. But yes, in the younger, less than 50 years old, they have a mortality rate of less than 1%. So they still get, and that's 1% is a good mortality rate. So they still get severe disease, and we should pay attention to anybody in any age category if their symptoms are actually not controlled. Yes, Akram. Did I answer the other question? What was the other question? Yes. Okay, Akram.
How effective the regular mask that we use like in the procedure room?
Right. So it's actually complicated. Now we should say that N99 and N100 is the best. We don't have those available. That's why we use N95 that can actually block 95%, but it's not 100%. So the surgical mask is less than that. And we're talking about hospital. Now, the WHO recommendations are only droplet isolation and airborne isolation for aerosol producing procedures. However, those procedures could be nebulized treatment, could be suctioning, could be bronchoscopy or intubation. So, and especially when we intubate someone, come on, patient in a room and everybody goes in, difficult intubation, it's going to, patient has to be in a negative pressure room, has to be isolated first in preparation for this. So that's why the surgical mask in the hospital setting is not the way to prevent. It has to be N95 at least. It is not recommended to wear masks in the community. You should not walk around with mask. However, if it gets to a crowded, closed, non-ventilated environment, at that time it may block some of the particles that may be infectious. So it has some, but it is not well studied.
Doctor, what about weather? If it gets hot, so how much is going to affect it?
So we do not know, but now if you take a look on the map, you would say that the cases in the tropical areas are minimal. And this virus does not like heat. So it is in one of the studies with different temperature, it is actually inactivated faster if the temperature is higher. However, the coronavirus MERS occurred in Saudi Arabia. And we've seen cases in the summertime, very bad cases. The attack rate was not very high, but there are different reasons for that. So it is yet to be seen. It may go down by the summer months, hopefully. Zahir?
Just follow up on the mask
Go ahead.
some of the studies recently showed that outside of the mask, a physician who was exposed to a patient, they had a lot of viruses outside of the mask. So if you are wearing a mask and you touch the mask and then you touch your face, then you are transmitting the virus to yourself. Because outside of the mask will have virus in it. But one advantage of the mask, the regular one, is that it prevents you from touching your nose and mouth, which is one of the most way to transmit the virus. So even though that does not prevent you from completely inhaling the droplet, but somehow we're not going to be able to touch your nose.
It is a barrier for sure, and at the community level, it's not very effective at a large scale. At the same time, will you be able to get any mask in the market now? No. So think about if we have shortage in the hospital, what will happen? Thank you very much. So the purpose of this recommendation is to preserve the supplies. We need the hand washer or the hand sanitizer in the hospital. We need the mask in the hospital. We are in close contact. We spend time with our patients. We are at very high risk. I will not go into the room if there's no mask. So
Sure. So we're going to be monitoring this closely with the local health agencies and watch their recommendations. That's number one. And as his recommendation is, as long as there's an acceleration rate, we're going on a hold and suspending all the programs. So we're really just going to take it week by week basis and make a decision on this. And yes, I mean, on the plan of, in terms of emergency and having a stock supplies and what have you, that's something we will consider as well.
Yes,
Very good lecture. I have two questions. Number one, if a pregnant lady contracts the virus, what should she do?
If what? A pregnant lady.
Contracts the virus, what should she do? Number one. Number two, any recommendations for dentists?
Well, the dentists are at very high. You are a dentist, okay? So every procedure you do with this, there's a lot of aerosols. So you should actually it should wear goggles and N95.
What an axe. Instead of rotating to the right, rotate to the left.
How about double masking, the regular mask?
No. It has to be N95 at least. And have you put one of those on you? It's very difficult actually. Your procedure may go long for half an hour sometimes. Well, yeah. There's another question. So it has to be N95 and goggles. Now the other question, it shouldn't be any different than management of any patient. If a pregnant lady, we don't, as I said, we don't know with this virus if it is vertically transmitted to the fetus, but in other coronaviruses it did not. So the management should be the same. And we don't know if the mortality rate or the severity of the illness is higher in pregnancy. Go ahead.
People have been sending on WhatsApp that every morning you should hold your breath for 10 seconds and see if you don't feel like any pains to check if you have fibrosis.
That's not true. Thank you very much. No. Yeah, and WhatsApp. No. Zahir?
So to follow up on his question, that's okay. So I think it's very important for anyone to just listen to the experts in the field, because on Facebook there's all kinds of experts who are not experts.
Correct.
And they're saying that there's panic, this is conspiracy, it's coming from China. Don't listen to the experts, and some of them are actually community leaders who are underestimating the crisis like this. Just to let everyone know, I mean, this is the fourth pandemic in the world in the last century. pandemics are not labeled as pandemics unless it's really serious.
Correct.
The first pandemic was the Spanish flu in 1918, where 70 million people died. The death rate of Spanish flu is 2%, similar to, less actually than the death rate here. And at that time, everyone knew someone or more who died, their families or surroundings. So if we have similar transmission like the Spanish flu, and the healthcare system is overwhelmed, like many people expect, then we should expect the worst. That means each one of us would know people who will actually die, up to 6. So people have to take these things seriously. From the Islamic perspective, our religion is about public health. That's why we wash our hands 3 times before preparation for prayer. That's why the Prophet said, if you have bad smell, don't come to the masjid. That's why you can actually interrupt your mandatory prayer if you want to save a life. So all of the religion of Islam is about public health. So it's very important for our imams and religious leaders to take these things seriously and prevent any settings, including private prayers and also group prayers, from happening until this situation is under control.
Agree.
Yes, is it true that there was some report that the expectation is up to third to half of the U.S. population to be infected?
Well, it is not true. It is only speculation of what if 30% attack rate occurred. Now, with all those interventions, this is when I presented the epidemiological curve, the purpose of those strict interventions, the purpose of stopping the Friday's prayer and preventing the gathering and the big major meetings are cancelled, is to flatten that curve. So we will not see, actually, if it was 30%, we don't need to see that. 30%, that means failure of our interventions. So this is only speculation. If 30% attack rate, which could happen actually without any interventions. If you leave the borders open and continue the normal life, it may be 30%, and that's what happened actually in the Spanish flu in the 1918. At that time, the understanding of the pandemic was limited, and the healthcare system was very limited actually. In fact, this is a very common picture that patients in the one hole on the negative pressure ventilators in the ICU, most of those patients died. And this is the origin of mechanical ventilation during that period also, along with the polio. So the purpose is not to get to that level. Allahu Akbar, Allahu Akbar. Thank you. Thank you very much.